So these were a compilation of questions that I had initially on my own, then I sent a note to the faculty, and actually I included Jess as well, saying what are the things that we are going to hear in the clinic. And this is really, the question for you to all think about. Your patients are going to ask you these questions, and you need to have a thoughtful answer, because a lot of them don't have great data. Some of them are complete myths. Some of them are very emotionally driven for one reason or other. And you should have a confident answer, even if the answer is we're not sure. But that was really the concept here. So I'll spread around the comments to the group, and we'll see how this goes. We talked about this a little bit, and I don't want to focus too much further, but Dawn, you made a great comment earlier about some interesting data coming out about the exclusion diet. There are others, but just when, practical information, a patient sitting in the office, they say to one of our fellows who's now first-year faculty, and say, I don't want to go on meds, I just want to give a shot about my curing my Crohn's disease.
So if they ask that question, I say absolutely not. I said, diet, nutrition, lifestyle, those are all treatment options that we use with medications. And so it's not about one or the other, it's using it all together. And
great. So Brian, so then they say, well, I really, really want to try it. Like, I'm not going on these drugs, I'm going on this diet. What should I do with that? What's your monitoring strategy of a patient who says, and some of them get dug in. I know we all have patients who are dug in on this. What's your strategy to take it from there?
Right. So I think the first point I would say is that the diet may be helpful in perhaps managing symptoms, which was already alluded to. If we're going to go forward with that, they also need to appreciate, and this is a point that has to be emphasized, is that Crohn's disease and ulcerative colitis is a disease of your immune system. It's not the disease of the bowel itself. It can present itself in the bowel. So for them to wrap their head around the fact, how can my diet impact my immune system dysfunction, that perhaps leads to some caution in their previously appreciated hypothesis. But regardless, if the plan is to go forward with that, and in that shared decision-making, at that point, it would be probably reasonable. We want to make sure the inflammatory burden is optimally controlled. So we pick a strategy, whether it be fecal calprotectin, blood work, anything that would be reasonable and something they would accept as you follow it, and to really see if it's going to work or not. So you have to have that buy-in, and diet, it makes so much sense for them. Like, what they eat should impact how they feel. And in many regards, it's true. But then they need to realize what Crohn's disease is. And Crohn's disease is when the immune system's not working properly. So that point, I think, should be highlighted for them.
I like that, Brian. That's a nice approach. David?
I agree with everything he said. You've heard of treat to target. You can talk to them about eat to target in the sense that, if they want to try something, here's some general recommendations. Let's distinguish diet from nutrition, and how will we measure it? I agree completely with what Brian said. The other question that comes up, of course, is did diet cause my Crohn's disease? And that's a more complicated question, and the answer may be probably, maybe. But the reality is that once the horse is out of the barn, if this was a developmental issue in the way your gut developed adaptive immunity when you were little from ultra-processed foods or carrageenan or other weird things, the point is you have it now, and we need to figure out how to get you into remission.
Great. Thanks. I'm not dismissing the concept, but I want to try to get through 8 or 9 of these if we can.
Can I say one more thing?
Yeah, go ahead.
But I think sometimes when people do come to you and they want that, a lot of providers just shut patients down and just won't even be open to listening to what they have to say. And so I think by listening to them, what they want is important, and so working on what they think is important, and then you getting them to understand what's important overall, and tracking everything and showing them whether it did work or didn't work is important.
Yeah,
Yeah, but also don't dismiss that by changing their food, they may have symptom resolution, some improvement.
of course.
Which is the immediate goal of a patient, right? So in a way, the last thing is to come and say, diet is the cure for Crohn's, is the idea that there will be some improvement, and they could tie it. Every time I eat this, which is fine. Don't dismiss that that's something that makes them feel worse, right? I just wanted to highlight
Don't
that
wait for them to bring it up.
Yeah.
I always say, tell me about your diet. Like, don't wait for them as you're like leaving the room. What should I eat? Like, that's not the time to, because then it seems like this is not anything we even thought about. So I know it's a hard visit and there's a lot to cover, but you should say, tell me about your diet.
Yeah. to enforce that, and then Millie, I'm coming to you, and then Parambeer about surgery. When we put this shared decision-making video together a while ago where we had all the different medications and we tried to be really fair about how to present the benefits and risks, we showed it to these focus groups, and they came back and their only comment was, you need to add diet in there. So David's right, you need to address it in some way, otherwise they're gonna think we're either don't know, hiding something,
Don't believe it.
right.
Don't believe it, yeah.
Millie, I'm going to ask you to comment on ulcerative colitis here, and then Parambeer, I'm going to come to you about Crohn's disease, particularly maybe short segment ileal disease. So Millie, this is what
Right,
our
no,
patients
I submitted
think.
this question, but I submitted it more for Crohn's disease. So
Yeah, that's why I mixed it up.
this is from an ulcerative colitis standpoint. Obviously, it is a little bit of a different beast because when you're talking about UC surgery, this is a colectomy and potentially J-pouch or permanent endoleostomy. And so a lot of patients feel like, I want to try everything before I move on to that step. And that isn't always the right answer, because we talked about the fact of diminishing returns, of severe inflammatory activity, of the fact that for many of these patients, it can actually become life-threatening. And so really this idea of I have to try everything, we try to steer them away from this. We want to try everything that is potentially effective in terms of treating your underlying ulcerative colitis. But frankly, once you've been through UPA, if this isn't working and you're in the hospital, I'm not going to try ozanimod or etrasimod. That has zero returns in this scenario. And so you have to think about what drugs they've been on, and is there a therapy left that could really be of benefit to them. And we talked to them at that point about the fact that they have been through every effective therapy, and we don't expect any further returns by continuing to give them corticosteroids.
Can I make a comment?
Of course.
I had a really emotional moment in clinic 2 Mondays ago. It's a freshman in college who wears a pull-up. She has failed, and she's in the dorm, right? She's just starting college. She failed everything traditional, failed combo, UPA plus whatever magic was happening. And she had been told that surgery is something for her to consider. So when she came to me, UC. But she couldn't make it to the toilet. She was in the dorm. She was pooping in her pants. I mean, it was just an absolute, it's still, it's very emotional when you have a freshman who's wearing a diaper. Don't forget to ask, because 50% of your patients are wearing one at least once a week. If all of you are not shook by what I just said, you should all be shook, and you should, because we were even shook by the confined, what?
Really?
Yeah, actually, David had a study, the GAPS survey
50?
study, that showed
50% of surveyed from both Crohn's and UC in the Confide survey, which is an anonymous patient survey.
Yeah.
46% wore a diaper at least once a week. Yeah, you see that? Okay.
Or a pad.
or pad.
But,
Yeah.
Right.
Nappy, whatever
Right.
the heck it was in
Excluding
every country.
fistula.
This was a
Maybe.
UC.
Oh, UC. Huh.
So that's why I say to you,
Ask, yeah.
when we saw the results, like, I'm not kidding, it should have been one of the most things that really
Yeah.
shook us over the last couple of years when we saw the Confide. But I'm only saying that to say that ask, because it wasn't until I got it out of her, like how many times she go in the restroom, and she single room, and she said, well, I wear a pull-up, that she still wanted to try everything possible. I was like really trying to understand what she was going through, and her life is so awful. But the idea of surgery, although she does say that everyone tells me that no one wishes they didn't do it. She did have that conversation because someone told her that, and that is, I'd have to say most of us would say that even if they have the worst pouchitis, they still are better than where they were before. So I do understand that. But I want everyone to understand what Millie said, is that it's typically on us to tell them and give them the lifeline to do it.
I actually use the term permission.
Yeah, so lifeline
and I
permission,
think
yeah.
I know it seems crazy and overkill, but at diagnosis, when I'm talking to people,
You'll say
I say,
validate.
just to let you know, like, there is another option here. And of course, everyone says, no. But that is very different than saying, after your patient shows up, that after their second or third drug, say, I'm just going to remind you, we had this conversation about surgery, and it's okay to do it before you've run out of every option and you're absolutely miserable. And I do feel like patients need that permission to opt out of keep going.
And I think it's really important for them to talk to other patients too. One of the things we do, and I would encourage you to do at your centers too, is when you've had patients who've had a J-pouch and they say they're willing to talk to other patients, then keep their name. Because it's really helpful for these young people at age 18 to talk to somebody else who at age 18 had this surgery in college and trying to understand what it's all about. The things we can't answer, that has been transformative for my patients. And after they've talked to someone and they have the surgery, they want to be on that list because they want to be able to communicate with the next group of people who have questions about this.
Well, I have two comments. The first one is I tell patients this is about them taking control of their situation. And I also tell them that despite our advances in medical therapy, this is the most effective strategy to treat their disease. And of course, we have to deal with some consequences downstream, but we're good at monitoring those, and sometimes we're even very good at preventing them. But the reality is that this is about regaining control of their life, and I think that's very important. There's always another treatment that's on the horizon, but we have to put things in perspective, and sometimes we need to send them to another colleague. Like I said, I understand what you want. I want to honor your wishes, but I think it might be helpful for you to see one of my colleagues so that I can best support you. And I send them off for another opinion.
And just to finish that story, and Paramber's story, is that she was, totally no tears, calm, telling me about her wearing a paddle, no issue. And it wasn't until I said to her, this is not acceptable. And I validated how this was not acceptable. That's when, she was so tough, and then literally, her and her mom just, broke down that she said, thank you for validating how I feel.
Important.
I'm shook also now. But just that magical moment of validating that this is not okay and we could do better, because she had no hope that there was anything. But it was really a magical moment. I don't know if Jeff's is still on, but this moment of connectivity and validation, I think, was really critical to someone who was calm as a cucumber telling me she's wearing a pad all day in her dorm. I was more, emotional around it.
It's amazing what people put up with.
Yeah.
Brian, did you have a UC
Well, I was just going to
comment?
say the themes that you're hearing here is that perhaps this statement should not be in our language, and surgery complements our medical therapy, which is also why, as excited as we are of these advanced therapies, using it for the purpose of preventing surgery, having that frame, the conversation frame like that, could be detrimental to the patient, because if it doesn't work, then they have failed, which we don't like using that term, and they really try to avoid surgery. So I think that you have to be cautious in trying to explain why we're using medical therapy, and I wouldn't set it up as the purpose of avoiding surgery, because that may not be appropriate.
You're setting yourself up for trouble later.
Yeah.
All right, Paramber, we're going to do a little role playing. So Dr. Dulai, you seem like such a smart doctor and you have all your fancy medications, but I just heard there was a research study that said you can just cut out my Crohn's disease and I'll be cured, and I don't need medications at all. What do you say, very smart, tall, handsome Dr. Dulai?
You're actually right. So,
About the handsome part.
so there is some evidence that for a subset of Crohn's patients who have small bowel restricted disease, that you can sort of do an upfront surgery approach. And I think that's something that we as a field need to begin to acknowledge, is that the concept of disease sort of phenotyping of Crohn's disease versus ulcerative colitis and small bowel versus colonic and ileocolonic were arbitrary definitions that we created so that we could more easily classify patients. But biologically, we don't actually know what the distinction is. And there's some very good sort of data in a trial showing that for short segment ileal Crohn's, you could consider an upfront resection as opposed to sort of trying to do medical therapy first. And it's definitely on the table. So I think you're right on all 3 points: handsome, tall, and surgery as an option.
Yeah, you are right, you are tall.
Role playing, all the innuendo here. Come on.
So thank you. Other comments, guys? Has
Well,
this?
we have to take this, but we have to take this further, though. I mean, because now we have controlled data.
Yeah.
Yeah.
So I'll say, I just want to sort of echo some of the comments that are made. The things that I've been surprised with when discussing surgery with patients is that you're dealing with a population of people who don't know why they got the disease. At some point, they could have heard from people that it may have been their diet, may have been their environment, may have been their life, their stressors. And there is a sense of underlying sort of perception of responsibility to take hold of their disease. And so surgery for them is viewed sometimes as a failure on their part. And if you help them understand that it's not their responsibility to get their disease under control, and that sometimes surgery is not a failure, but actually just the right course of action, it can really help them feel a lot less concerned and take a lot less responsibility and ownership for the outcome.
I like that, Parambir.
Yeah.
That's great. Brian, you were going to comment
Well, I
on,
was just going to say,
take
I
it
mean,
further.
we have the lyric data, which we've learned a lot about the value, how it could perhaps, depending how you're monitoring it, could be better than starting an anti-TNF agent. And then the Mount Sinai data, which we reviewed at our journal club last week. You're most close to it, if you maybe be appropriate, Marla, for you to speak on that. It looks like surgery is a very, very appropriate choice, even in the face of all of these biologics and advanced therapies that we have.
Yeah, I mean, that was using Copenhagen data and looking backwards, but it did sort of mimic Lyric in a sense that there are, I was saying to Millie that I wish we could identify that perfect patient where it makes sense, you limited ileocecal resection, there's elements of fibrosis outshines the inflammation, because usually there's a little bit of both. Who's the one that has dominant fibrosis that no matter what I throw at you, you're gonna end up there anyways? Other than obvious proximal dilation on a cross-sectional, that I think we believe is a risk factor. But the concept of knowing who that perfect patient doesn't even need post-op prophylaxis.
Yeah.
We don't even know who that person is, right? So I think what is interesting for me is to say that the way I frame it often is we use these drugs to help prevent where you are, meaning fistulas or strictures, like the end game has been reached. Why are we throwing a lot of medication at it? It is far easier to treat downhill than it is pushing a boulder uphill. So I explain to them that if we're in prevention mode, our drugs work better, you'll feel better. So I do turn it a little bit also and just say it's a lot easier to treat this way. Once you
Reset
start
the
over.
clock.
Reset it.
Yeah.
So there's some, again, you're hearing a lot. What I love about hearing from everybody, and Jess gave the patient perspective, is how we're communicating. It's all about how you communicate to patients. We haven't given you any data point that's that interesting to walk away from, but I really hope you understand that each of us have a different way of communicating the benefits of things that are these myths, you know?
The other myth people read online was that if I have one surgery for Crohn's, it's going to speed it up, and I'm going to have multiple, and I'm going down a slippery slope. And you need to, I don't wait for someone to ask that or to say it or to read about it online when they go home. You have to upfront say that that is the old approach to thinking about Crohn's. That is not what we see now. Yes, there's a risk for recurrence. We monitor you, and it's much easier to treat for prevention than to catch up from years of destruction and fibrosis. So you should, that's another thing, don't wait. You say, you may read that people have multiple surgeries after they have their first one. I want to disavow you of that because we work very hard to not let that happen.
I also upfront say that most resections will not involve an ostomy, and that's a real fear patients
100%.
have, and they don't want to bring that up, and they're nervous. So I think that's also a very important point to bring up proactively, that that's not the intention of this surgery. Multiple times in our clinic, you just see this, just relief, and then it's a very much easier conversation to have.
Right, surgery is black and white. It's either ostomy or no surgery.
Right, yeah.
Yeah,
Because then
Parambir.
the surgeon comes in and says, well, you might end up with
Yes.
an ostomy.
Right.
So you warn that, and I've had that
But
problem
you
too.
could
but you say
warn
that.
your patients
Right.
that your surgeons are not going
I
to be
do.
as
I do that.
gentle as
I
you.
100%
Right.
too.
So
Yes.
do that.
Said, don't listen to the surgeon.
Oh, I
So,
think-
Parambir, and then Dawn, I'm going to ask you how you talk to patients about this question next. So
I was just going to
Parambir.
say, to end on the surgery part of it, I think one important thing is we talked about that ideal sort of lyric trial, which is short segment, non-dilated sort of ileal stricture, or ileal sort of inflammation, right? But it's also important for you as a provider to be willing to recognize for yourself that, okay, this is not something I can fix medically, and I need to offer surgery, like a very strictured, narrow, fibrotic ileal area, or something where you say, look, I'm not going to waste 2 to 3 drugs for something that's not going to work.
Yeah.
You have to accept that I need to accept that my medications aren't going to work, and I need to ask my surgeons to step in. And
It's
that,
a learning curve.
I see sometimes is also a barrier, is you want to fix this. But sometimes you fixing it means you sending them to the OR.
Oh, and another, of course, we could go all day, but what made me think about, again, is a trigger, also, it's the preemptive of, you know what your patients are most gonna ask you next, so there's a laundry list here of things to anticipate, which I love as well, because you all have heard the next question, you're like, I'm gonna stop that from even being asked. I try to explain to my patients who feel okay, are adjusting their diet, and not eating the foods that give them the partial bowel obstructions, and try and get them to understand it is far safer to operate electively than it is when you come in with a bowel obstruction and or a fistula because you've blown a hole above that stricture. So being able to have that authoritative way, not in a paternalistic, but with confidence, that what we're trying to do is prevent you from having an ostomy bag and a perforation, et cetera.
No, and that's what's so important to explain to them is that in an emergency scenario, they're going to have an ostomy 100% of the time. Once someone is obstructed, think about it, the bowel is much more dilated above. You can't sew dilated bowel to narrower caliber bowel and not have a leak, so they divert above,
Well,
right?
I can't sew bowel either way.
Yeah, well, true. But the fact is the elective surgery is much less likely to have the ostomy. And so kind of when you present it like that, it often makes them realize, oh, I should go ahead and do this and not wait.
I love this session. You can see why we do
But
this,
the
right?
first
We can-
time you're going to send a patient for surgery, I guarantee you're going to be second guessing. Like, did I really?
Right. We
did
coulda saved
they,
them.
Did they get optimized on every therapy? Like, what is? Because it's a big decision, right? And it's you now making that recommendation. And so don't be shy. One of the most important things, I want to echo what Brian said, I think, or Parambir, that you need to know your limits and when you should get another opinion, or just call one of your colleagues, or us. You know, part of this is networking, and we want to be available to our future partners and the leaders of our field.
Yeah, low-hanging fruit, if you can't get your scope through, send them for an evaluation to the surgeon. Start the conversation. If you can't get your scope through, in the ileum, you know, I'm using an example of the ileum that has a stricture or you can barely see it, pinhole. It's not the time to be probably negotiating. You should just do cross-sectional, see the length of the segment, figure it out, get your surgeon involved. That's a low-hanging cue. That, you know, enough for us to feel more confident around it. Yeah.
Good, great. All right, Don, we all know the answer to this, but we want to hear how you talk to your patients about this, as this is something that I still can't believe I'm having conversations so frequently about, you know, my life's over if I have an ostomy, I can't do
Well,
anything.
I think a lot of it's just what they read and what they see, but I think in this situation is where I do what Millie does. Like, I have patients that have ostomies, and I have patients that have pouches that I'm like, and I start talking to them like, well, I was just like, you can talk to my pro hockey player. I was like, do you feel like playing ice hockey is pretty active? And everyone's like, yeah. And I'm like, okay, well, I have a hockey player who has an ostomy. I have a patient who just ran a marathon. And so really just talking to them about examples of patients that we've had and then connecting them with a patient. Because again, no matter what we tell them, sometimes even when you're communicating, they still feel like you're talking at them. They really want to talk to someone who's lived the experience and walked the walk. So going it through it, but then connecting them with that, you know, that community person, or even anybody online.
Great.
And I would just say, if you get this question, I do the exact same thing and sort of exposing them to other people and giving some of those examples. It's worth probing if there are specific activities they're really worried about. You may be surprised. They may be wondering about not just sort of sports and physical activity, but sort of sexual intimacy, just a broader concept of their physical interactions with others and their physical ability to do things is something worth probing.
I think that concept in general, when it comes to risk and worry, just ask them. Like, they are, you know this, right? They tell you everything in that room. It's like this sacred space of honesty that they will never say anywhere outside, that they're worried about sexual intercourse or they're worried about some, you know, thing that they didn't want to admit they really miss out on. But just ask them. It helps so much in directing your answer, as opposed to spending 20 minutes and they're like, I didn't even really care about that. What are you talking about?
And sometimes it's something like swimming. And
Yeah.
they can swim with ostomies. Absolutely fine. And so things that they just kind of are even afraid to ask because they feel, well, how do I even go about asking this question? Is it ignorant? You know, et cetera. So.
I had, my best was a scuba diver who asked actually a question about how pressure and descending. I was like, well, we're going to find out. I don't know. Right? Is it a rented suit or is it yours? No. But anyway, he did fine, by the way. All right, I want to get to this next question because this comes up all the time. Dawn, I'm going to start with you and then ask others about, how they address this. And this, I feel like, Perenberg, you brought this up earlier, that patients are worried they cause their IBD. I think, Marla, you brought this up in a way too. This is a really hard one, I think, to try to get to, make patients comfortable with this concept.
Yeah, this is a hard one, especially just to answer it in one thing. I do get a lot of people that do ask that, and I reinforce them that there's not one thing that they did or they didn't do that caused them to have IBD, because I do feel like at the very beginning that they don't understand why it's happening and they want to blame on something that they did do or they didn't do. So explaining to them that that's not the case, and that stress is that we know that stress is a trigger for symptoms, and stress can be a trigger for some patients, but it's not just the environmental trigger. You have to have the genetics, you have to have the autoimmune changes and things like that, and stress definitely makes the symptoms worse, as it makes all of our symptoms worse, even if you don't have IBD, right? And so we do talk about that a lot in my clinic, and how we can control stress and build resilience and all of those things.
So, Perenberg, I'm going to come to you in a second. Marla, you brought up, a patient I think that's just heartbreaking, right? When you meet these older patients who thought they couldn't have kids. Why don't you have kids? Well, I was told I couldn't, or I thought I couldn't. But one of my most heartbreaking patient stories was this brilliant, guy who said he really wanted to go to medical. He just, casually said, I wanted to go to medical school, but I knew I couldn't. I was like, why? He said, well, because I heard it was going to be too stressful for my Crohn's disease, and I was never going to be able to get through. And it's like, like they just live with this fear and anxiety about their fear and anxiety. That's really difficult. Perenberg, did you want to make a comment here?
Oh, I was just going to say that I think it can be hard for patients to sort of understand sort of the relationship between stress and IBD, and then how IBD is contributing to the stress. So what I tend to do is say there could be some relationship there. It's definitely not causal, but it creates an opportunity to have a discussion for them to have a focal point of how to manage their stress, because either way they have to manage their stress. Either it's from the IBD causing their stress to worsen, or they feel like their stress is sort of causing their IBD to flare. And it just does create a natural opportunity to sort of create a focal point for the stress and the anxiety and the psychology behind it, and see if we can sort of dovetail into a different conversation, but not acknowledging that they had any contribution to it.
Yeah.
And
No, go ahead, Bob.
I was just going to say, just to add to that, so how I emphasize that relationship is to say it's certain that stress leads to some issues related to their IBD, but we need to make sure their IBD is well enough controlled that their disease remain controlled despite their stresses. And then you get that, you hear them 6 months later, you're seeing, I had all these stresses with this, that, and the other, and I was so happy that my IBD did not react to it. So, and that may relate to control or optimizing their mental health issues, but then also optimizing their disease. That we need to get you to a stage where this isn't a trigger, and that is a multi-pronged approach.
Yeah, I think just a couple points is that what stress is going to do is it's going to impact symptom burden. So separate, right, objective nature. There is, I'm sure, influence, and there is particularly in animal models and other spaces where inflammation is absolutely tied to psychological stress and resiliency using microbiome and responses, and there's a whole IL-6 and the vagal nerve stimulation stuff and acetylcholine. There's a definite, my biology friends over here could explain it better to me, but this concept of mind-body dysregulation. What we do know is once pain becomes centralized, it starts peripherally. There was legitimately an event. But if they have underlying anxiety, stress, depression, underlying psychological, true mental health comorbidity, then they're not able to manage, and they can't self-manage. And I think what everyone is saying is that they need to have tools to how to manage their stress, because it will notoriously lead to isolation, lead to anxiety. It's, as Dawn was making this thing, is she's telling you that once it starts, it's a vicious cycle because you can't get it out once it's become centralized. So the key is to work on mind, body, brain, gut, behavioral health approaches, and get your patients to see a GI health psychologist, not just a random psychologist who does talk therapy. This is actually not what we're saying. These are individuals who are trained to actually manage this gut-brain dysregulation. They become disorders of gut-brain, interaction. So don't dismiss the idea that there's probably an inflammatory aspect of this, but that's we don't get into that as much with our patients, but I think understanding the impact on the symptoms and trying to get them to understand the disconnect between subjective influence of stress and objective influence of stress. I'll tell you, that's where ultrasound has also been so helpful, because they're panicking, and I'm like, come on over, let's look at your disease again. Nothing there, right? Gives
great.
them even more of, something to hang on to, that we need to start focusing on my mind and my body and how they're interacting.
I'm going to make one comment of why I put this in, and then David, I'm going to give you a co-director's prerogative of last comment after this, and then we're going to take a break. I urge you, when you have a patient with a J pouch that has some inflammation in it, even if it looks like Crohn's disease, I beg you not to walk in the room and say you have Crohn's disease. That's not what Crohn's disease is. There are some legitimate people who get Crohn's disease that, whether it was missed or whether it just evolved, that have real Crohn's disease of the pouch, but most of what we see is not. And I think there's such a psychological implication. Think about what we talked about earlier, about the decision-making around colectomy and how much they stressed and talked to 100 people about it and probably waited too long. And this is what they were worried about, is that it was the wrong decision. And I have just seen people deflated and literally have PTSD from a surgeon going in saying, you now have Crohn's disease. And it's incredibly disruptive. Again, there are exceptions where it's absolutely correct, and I'm not saying to hold off and lie to them, but most of the time that's not the case.
Okay, so the first thing is what you tell a patient who's going to have surgery for their colitis. They're going to have surgery for their colitis. They're not having surgery that cures them of their IBD. So they have IBD. It's a overactive, uncontrolled, constitutively stimulated immune condition of their intestines that may be restarted when they have a new anatomy with stasis, microbiome, bile, and whatever else. And I don't say that they're going to end up sick again, but I make sure they understand that this is going to get rid of their colitis and their colonoscopies. It's not going to get rid of them from having the potential for inflammation in the future, and that we're learning more about this. Number two, when you do make a diagnosis of inflammation, be descriptive. And even if it does look, as Corey said, like this is what we would call Crohn's, it's pre-pouch ileitis with patchiness, or they've developed a new perineal fistula that's distinct from the surgical healing, and it's not a technical complication. You can describe it that way. You can say this may be like Crohn's disease. It may even be Crohn's, but you got to be really thoughtful about how you communicate. From the standpoint of medical and thinking biologically, we've been trying to separate these things out so we can study it better too. So there's lots of different types of, quote, pouchitis. And then there's pouchitis that actually, in somebody who really did have Crohn's, they had an intentional J-pouch with known Crohn's, that sometimes is done. They had a J-pouch where when the colectomy specimen got to the lab, the pathologist said, oh, there's granulomas, or there was ileal disease that's chronic, and this looked like Crohn's in the lab after the colon was taken out. There are reasons that it may have been Crohn's before they had surgery. And then there is what I call inflammation of the pouch with Crohn's-like features, patchiness, ulcers. Yeah, okay, but don't get carried away. And then you also explain, I might call it this just so I can get you medicine from your insurance company. But I want to be clear to you that this is a separate problem, and we're going to work together to try and manage it. So those are all my bullet points.
Great. That's a great way to finish the morning. I want to thank all these thoughtful comments. As you can see, we can talk about these topics probably all day and find that we agree on a lot but disagree on some, and we always learn it from each other, I think, when we listen to these discussions as well.